Hello, my name is Jim Wood. I serve as Strategic Counsel to the 501c3 Nonpartisan Concerned Actuaries Group, and it's my pleasure to welcome you to this second program in a series of discussions about the need for more informed healthcare decision-making in what we call the American Healthcare Now What series. The first program in the series, called The Context, focused on the proposition that the American healthcare system, as currently configured, could not consistently deliver affordable, quality healthcare equitably when and where needed. In that broadcast, the distinguished participants concluded their discussion with the observation that the symptoms noted were driven by a serious lack of alignment between needs and resources.
And my first one I'll cite is the sustainability question. Think of something like 7% of GDP back in 1970, and it was maybe 14% in the year 2000, and determined to get to 20% and perhaps beyond. And that's, I think, not sustainable.
Price controls always create tremendous unintended consequences. And we have put in so many in our system that it's driving all these unintended consequences, and it's created rough situation for the inner cities with hospitals that are highly dependent on Medicaid patients and the rural area.
Right now, it's incredibly fragmented, and we don't even have enough data in order to be able to make informed decisions with regard to coverage, cost, and quality. And by the way, that's where the concerned actuary groups come in. We need much better data to be able to make more informed decisions to get us from where we are to where we need to be as it relates to coverage, cost, and quality, and as it relates to affordability and sustainability.
The second program in the series, The Disconnect, is focused on that conclusion. More specifically, the discussion centers on the proposition that there is an operational disconnect between the coverage and benefits being promised and the ability of the budgets, infrastructure, and managerial oversight available to deliver on what's been promised. Discussion leaders include Eugene Sterling, co-founder of the Urban's Brookings Tax Policy Center, Margaret Stanley, former director of Puget Sound Healthcare Alliance and senior VP of Regents Blue Shield, Joshua Gordon, director of health policy for the Committee for a Responsible Federal Budget, Mark Litto, retired Milliman principal, and Bob Shapiro, retired founder of the Shapiro Network. Mark, why don't you take a run at the usage and subsidy disconnect?
Thanks. There is a big disconnect in the budgets, but and a lot of that, of course, everything is holistic and interconnected, and there's quite a disconnect between usage and subsidies. If you think about the current system, we have many people that are uninsured or undercovered, and what that means is they're not really getting enough subsidy. When that happens, they delay their treatment. They tend to get sicker or their health status gets worse, and then they need more treatment later on. Very often that has to be subsidized by somebody else. And then we have an equal, if not larger part of the population that get too much subsidy. And what happens then is, of course, they use much more healthcare than they need. And that overusage and overtreatment eventually takes away from other types of services and the ability to subsidize the people that need it. So there's a big disconnect, and typically what happens is we have a problem, people are underserved, uninsured, so we give them coverage. We often give them coverage where they go from no subsidy to either the right amount of subsidy, but in many cases too much subsidy, and we push them to the other bucket. And then, of course, we have people that have coverage, maybe they're locked in their employer and they lose their job, and then they become uninsured. And so we need to get our subsidy system right so it ties with the usage and when people need it and when they don't need it or they have too much. And we have just done a terrible job in that realm of the system.
So I understand where the concerned actuaries are coming from. In simplest terms, it seems to me that they're saying that there's a lot of work in all our disciplines. That's not just actuaries, but economists like myself, accountants, people who deal with the numbers. We basically are dealing, especially when it comes to government programs, with an incomplete balance sheet. If you want to, an incomplete income statement. And there's this money that some or other is going to come in from somewhere, but we don't account for it. How that works out in the case of healthcare is if you look closely at the design of our health programs, and that goes from Medicare to Medicaid to the exclusion for, or the tax subsidy for employer-provided insurance, they're all open-ended. And they all, in some sense or another, give the power of appropriations, not to the Congress, but to the public, particular providers who then bargain with their consumers over what additional goods and services to provide, and often setting the price. And that doesn't work politically to have that type of incentive in place. But in terms of cost, it means that the cost of healthcare has been rising really forever for the last 30, 40 years faster than GDP. Now, when healthcare was 2% of GDP, it didn't matter a lot. But healthcare costs are now about 18% of GDP, about 23% of personal income for households. The average cost of a policy for a 4-person family is about $28,000. Total health spending per person in the United States is about $12,000. And yet we come out with statements like, well, people can't afford more than a couple $1,000s of insurance. Well, if we're spending 12, but we can't afford more than 2, or we can't afford more than 10% of our income, but we're spending 23, something's out of whack. And what's out of whack, as I say, in large sense, I think, and I don't want to carry on too far because I want it to be a conversation, is the simple fact that these systems, almost all the healthcare programs of the government, do not operate with budget constraints. And so there's this unknown future people, if not today's people, who are going to pay it. Now, sometimes that we borrow from China, or we count on the Federal Reserve to float some extra money, or we run large deficits, and that sort of hides who these people are. A lot of times the people who pay are hidden within the systems themselves, so we don't see it coming out of pocket. Out-of-pocket spending is still a moderate share of total spending, but it comes out of our wages. To a large extent, it comes out of our Social Security taxes, it comes out of our income taxes. And the result within the federal budget, and largely and more so within state budgets, is that health, and to a lesser extent, but retirement, are dominating, basically absorbing all of the growth and revenues of government. Together with interest on the debt, 130% of the revenue growth. So these systems are just out of balance, and it's these efforts to bring these systems back into balance and put the right incentives in place that we're trying to address.
To what Gene said, that we're doing all of that spending and have that unbalanced future ahead of us. And I think we all know we're not getting what we're paying for. And I think that's the both the kind of galling part of it, that we're spending so much more than every other developed country on healthcare and have this unsustainable future, and yet we don't have the outcomes or the financial security to show for that excess spending. But that's also our opportunity. But I think that inefficiency is our opportunity, that we can get better, set our healthcare on a path towards becoming more sustainable and not necessarily harming our health, and trying to make this sector of the economy, which is a huge sector, more efficient, which can also add economic growth to other sectors of the economy as well. So that's kind of what I think about when I think about this unsustainable future, is that we have this enormous opportunity to become more efficient and use our healthcare system for the better.
Margaret, you talked in the first conversation about the complexity of the system and how that affected the patient, and and obviously everybody who's spoken thus far in their disconnects is talking about, who knows where that money is going, or who knows how much you're being subsidized or you're not being subsidized or whatever. Could you talk for a little bit about how you see that disconnect between consumers and information?
In the first session, David talked about the importance of incentives, transparency, and accountability, and I think those are extremely important. You need the incentives in order to have providers change their behavior so that they are providing cost-effective quality care. And the only way they'll find out is through transparency with information on cost and quality. Experience shows that consumers don't use that information as much as we'd like. And it's been my experience that providers who really like to be A students will change their behavior and respond to reports on cost and quality. One example I remember is when the Washington Health Alliance put out its first report on comparing different medical groups on how well they were taking care of different chronic diseases and providing preventive care. And on the diabetes measure, a very well-known, well-regarded medical group was appalled to find out that they weren't doing as well as they thought they had been. And they made it the top priority for their clinic to focus on providing diabetes care better. And that's an example, I think, of how providers, given this information and given incentives to improve, really will. The problem is that we're doing some of that, but not nearly enough. Medicare is doing some, insurers are doing some, private employers are doing some, but it's not widespread enough to truly be effective. And the answer really is to weed out care that is unnecessary or is unnecessarily expensive.
Could you give me a couple of examples of where you see a disconnect in terms of what people, information they did or did not have, and its impact in terms of cost or behavior?
I think that the individual consumer has to choose a health insurance plan. And in the case of Medicare, the information is completely overwhelming, particularly in the Medicare Advantage program. At least with Medicare supplements, you have standardized benefit packages so that it's more like a commodity. But with Medicare Advantage and with the prescription drug program, people are completely bewildered, and they will stay in a drug program that is costing them more than it should for the drugs they're taking. But it's just too much work to analyze all of this. And I remember when I became eligible for Medicare, my stack of information on the Part D program was about 4 inches high. And I just wasn't willing to go through all of that.
Bob, I know that one of the things that drove the creation of the Concerned Actuary Group was a concern about the what you saw as the lack of management discipline when it came to the healthcare system. And I wonder if you could talk in terms of disconnects a little bit about the disconnect between perhaps legislative intent and how the programs actually operate.
In the private industry, the executives have a responsibility to keep the company solvent and also meet the promises they've made to their customers. And there's a system, a discipline system for doing that. That starts with clearly articulating what the program reform is, the way that reform will be managed, and what the assumptions and data should be used to quantify and project the expected results. And they will compare what's happened in each area, et cetera, against what's actually experienced, determine where there are differences, determine what happened that they didn't expect to happen in terms of behavior, and adjust the program to make sure it stays on track long term. In the Washington way of doing things, the process is rather one of, this is the way we want to design the bill, and this is how we were going to manage it, here's how we're going to quantify it. It's more, how do we make the numbers come out in a way that we can get okay? So it's sort of working backwards, and it makes it possible to actually manage the program with the discipline citizens should get. What's missing is the process of evaluating the actual results from period to period against what was expected and projected when the bill was originally quantified. Without that process, that discipline process, one can't expect the program to meet the sustainability and fairness.
Jump in there on the definition of catastrophic, which I tried to lay out a bit of the numbers. If it's $12,000 a person, and most people consider a few $1,000s beyond what they have cash savings to pay, which is true, which is catastrophic, you do have a disconnect between what's catastrophic and what's not. And I think merely asking people to pay for items that are less than catastrophic doesn't get it where most of the money is. Because most of the money is going to be in that area that most people consider catastrophic. The way that I think a number of people have argued, and I'm going all the way back to Alan Enthoven, who I like to follow, argues is that the time you can get the consumer involved, it's not when he or she is on the operating table. It's when they buy the insurance package. You know, they want a fairly good package. They might accept the catastrophic package if they think they've got enough self-insurance to cover items below that. But it's the time of buying the package that you've got to get them involved. Otherwise, you basically are going to have to depend on government regulation to determine the answer. And I think we'll always go back and forth on the extent to which we can ask individuals or ask government. My main point is right now we're afraid to ask anybody to basically set the limits. We're afraid to ask the insurance companies because we don't trust them. We don't think individuals can cover the catastrophic expenses, so we don't want to put it on them. We don't trust government for overriding reasons having to do with government. But at the end of the day, somebody has to be able to say, no, this is not worth it. And by the way, being not worth it is not just waste. That's where a lot of people get mixed up on this. They're looking for the $1,000 hammer that's going to save the defense budget. Because wasteful means, or inefficient means you're not getting your money's worth. I'm spending $2 and I'm getting $1 worth of care. So you can't just tell people you can't have that $1 worth of care if they really need it, because it costs $2. You've got to have a way of reducing those costs to those places. And I have to say, and actuaries understand this, it'd be harder for a larger group. There's another balance sheet here. There's another income statement. For every dollar of care we buy, there's somebody on the other side who's getting the money, right? So every dollar we pay for some care is going to some doctor, some insurance company, or somebody else. And so you got to worry about both sides of that equation. To the extent we involve consumers, I'm arguing, I think we get them involved at the time of insurance purchase. To the extent we get government involved, it's going to be more regulation, but government might be able to, they've got the vast majority of the budget now. You might be able to get them involved in the way they set up the policies and the options they offer to people.
So absolutely fascinating. I think the question of disconnects, you've all given great examples, in my opinion, of what we're talking about here. I think the question that we need to take a look at is, so why do we have these disconnects? This is not a country full of stupid people or people who are not well-intentioned. And so ultimately, the question of why is this happening? I get the idea there's a disconnect between the amount of money coming in and the amount of money going out. Why haven't we done anything about that? Why is it so difficult to grapple with that particular fundamental? Everybody's, it's the old great political line. It's the kitchen. Everybody sits down around their kitchen table. They have to balance their budgets. Why do we have so much trouble balancing budgets when it comes to healthcare?
Building on Gene's last comment, where your $1 of spending on one end is someone else's profit on the other end. And I think our system developed over many years with some accidents of history and a bunch of other things to have this kind of fragmented system. And now when you look to reform it, the big challenge is that fragmented system is very effective at stalling congressional and policy making action, especially when people's livelihoods and profits and jobs are at stake. And this kind of brings up the big conundrum that if you try and incrementally make changes, that means targeting just one area of special interest. And our system is very ineffective at fighting single areas. You need to have kind of trade-offs encompassed in whatever solutions that you're selecting. So you'd like to have some carrots and some sticks. that involves sort of thinking bigger. And so we have a situation where making small incremental changes is very difficult in our political system. But right now, making very big changes is also very difficult in our political system. So I think that is because of partisanship, it's because of our institutions. And again, I think this inefficiency we talk about when we talk about the US healthcare system is something that impacts so much of our economy and everyone's lives. And so any choices you're making, even with all of this inefficiency, wind up having winners and losers about something that is the most personal issue that Americans deal with. But there are opportunities there. And I think that you can develop bipartisan agreements to attack some of those inefficiencies by pointing out market failures, lack of information that kind of reinforces those market failures, and start kind of unwinding some of them. And we actually have done some of that over the last 5 to 10 years. And I think there is a pathway forward where we can do some more of that incremental bipartisan or at least under the radar change that can start moving us into a more efficient healthcare system. And that's maybe the best we can hope for right now.
I think we have plenty of evidence that the healthcare system will respond to incentives. If you look at when diagnostic related groups was introduced by the government for Medicare many years ago, the length of stay in hospitals went down dramatically. And there have been a number of efforts by purchasers either working independently or forming purchasing coalitions to try to influence the healthcare system to provide better quality at lower cost. And these have been effective to a degree, but it doesn't represent a large enough part of, say, a hospital's or a medical group's revenue. So if more purchasers joined together and agreed on common incentives and common measurements and transparency, I think we would have better success at getting the healthcare system to change, but it's been too incremental and on too small a scale.
I couldn't agree with you more, Margaret. I think these have all been improvements. A lot of them have been moving in the direction of bundling goods together, so they're bigger and bigger packages. Might not be Medicare Advantage, which is a big package, or an HMO, but we're moving more and more in that direction, which I think is starting to limit. Maybe Josh was getting at this too. It's starting to limit the opportunities to break outside of that bundle. So when DRGs came in, they were efficient in many ways, but hospital administrators found great ways to find other ways to buy very expensive health care. The drug companies figured out ways, in fact, not just if they had patents, but even if they were off patent, to quickly quintuple prices because it's going to take a few years for some competitor to come in and compete. So the system has been enormously efficient at offsetting those efficiency gains.
I would follow up on what all three said. There's a real, and Gene's talked about this actually quite a bit in a different sense. There's really a big disconnect between demand and supply in this country. So if you look at historically what happened after World War II, as Gene mentioned, we created premium tax exclusion, which created quite a demand as a substitute for health benefits instead of wages because employers couldn't afford to give wages. That led to Medicare because people retired and they were not paying much for their health care, and suddenly they had to pay a lot because there was no coverage. So now we brought in the seniors, and once we subsidized them substantially, they demanded a lot. Medicaid for the system for the poor came with that. And after that, it's been one group after another, whether it's coverage for pre-existing conditions, old age, coverage with community rating, mandated benefits. So we've continued to focus on meeting the demand for all these things. And when that happened, what did we do with costs? We have to keep putting on price controls. So we put on DRGs in '83, RBRVS for professionals in 1991. Now we have 340B for drugs under Medicaid. And we just keep putting on more cost controls And when those cost controls cause providers to not provide services for certain populations because of low reimbursements, that creates a health status. So all these items from coverage, cost, health status, access, the economic effects that come with those dislocations are tremendous. So we have a huge disconnect problem in terms of demand supply, which ties into all the items the speakers were just talking about.
All of you are describing a circumstance in which there is a winner someplace for everything that's going on in the system. And so when you try to stop doing something that's going on in the system, the winner steps up and argues, and because there is a lack of transparency and the consumer is not aware of all the bits and pieces and where the due bills come out all the time, how do we deal with that incrementally? I mean, don't you have to find some sort of master stroke?
Well, I think reforming the whole system, I think, is an obvious answer, but trying to get agreement to do that would be very hard. Like one of my favorites would be to essentially capitate states and then capitate subportions of states. So you have a fixed amount of revenue and you have criteria for what the system must provide. And so they need to make decisions within those constraints. But it would be very difficult to get anybody to agree to that kind of change because it's too disruptive. So how do we find a path from where we are now to improvements that will give us better quality and lower cost? I think what we talked about earlier of providing incentives, having good information, and holding the provider system accountable is the way to do it.
Talk for a little bit, if you would, all of you, about why consumers have such poor information.
It's too complicated for them. And when you look at it, how much did they really choose? They choose their primary care physician, they choose a health insurance plan, they'll choose a pharmacy, perhaps. But then most of what they get in healthcare is what's recommended by their physician. I mean, they may choose whether to get a new pair of glasses or whether to get a crown on their teeth. But if their doctor says they need a heart operation or they need to come back for a checkup in 6 weeks, it's the doctor really making that decision. And I think that's where we need to focus our incentives.
But we've talked about the disconnect in terms of revenue and who's paying for what, who gets what, and all the rest of it. Why is that body of information so complicated? Why is that not more evident to people? I mean, Jane, you make an argument in your most recent article about people not understanding what they're paying for, who is paying for what they're getting. And David Walker in our first conversation talked about people not understanding what their employers are paying for coverage, et cetera. Why has that not become more of a focal point?
The article you're referring to was sine qua non, which was done for the Altarum Institute. But think about Margaret's example of wanting or preferring something like a per capita limit on state budgets. If the initial budgets provided to them were per capita and Congress could allocate increases over time to cover additional items, most of the public would be happy with that because they feel like they're getting more. When you have an open-ended system where the costs are rising forever at an unsustainable rate, then the job of Congress is to take things away from people. The job is to renege on past promises. So that's, maybe I'm jumping ahead, but that gets you into the political dynamic of the current system. It's compared to a system that's promising more than it can ever deliver. Any reform, I don't care who on this table provides what reform they provide to get cost under control, is going to look like they're mainly creating losers. And that's because people who are paying the cost, the actual ultimate losers, are not identified. You go from not identifying them, maybe because of debt or something else, to identifying them in the politics that's creating losers. If you would start off a system where these various items were in a budget, a sustainable budget, you could add to it over time, Congress and the politicians would be thought to be giving more to people. But when you start the system that's open-ended, where we can demand what we want, providers can charge, not entirely what they want, but a lot of what they want, I just don't think that's a possible system to survive. So I think it's actually got to be a big jump to agree that we're going to put caps on the system and then let the caps grow through legislation or through agreements with employees and employers to increase their subsidies. But if you don't sort of start off the cap system, any reform looks like it's only creating net losers. And it does because you've got this, as I say, this unsustainable comparison. You're comparing a sustained system to an unsustainable one and saying, well, look at all the losers that are being created.
The problem is even deeper because we disconnected the patient from the physician. The patient-physician relationship got totally distorted by the way we put in all the subsidy systems and risk transfers that we've put in. And so part of the problem that you have in single payer systems, though England has a cap, but they disconnected the patient from the physician as well. And so it's not, you need the budget, absolutely, but you have these other fundamental disconnects in the system besides budgeting that have created and not having the patient aware of cost while they're getting all the services. Again, it's a huge demand supply problem.
Why is it an either or situations? My bias is that the public, like everybody on this panel, makes decisions in their own best interest. Once they're safe and secure, they're willing to consider other people's needs, etc. But they're not getting enough information to be able to make that choice. If I were to get, as a consumer, if I was to get a monthly or a quarterly report from the federal government on what I paid in and what they were paying in and what somebody else was paying in, why wouldn't that begin to have some impact on how they interact with the system or how they interact with the politicians? I mean, you're describing a situation, it seems to me, and I'm saying this to be argumentative, in which the incentive for the providers and the United States Congress is to con the American people about what this stuff costs. And that doesn't sound to me like a fair description of either providers or the United States Congress. So I'm confused about why we can't think about how to get more information into the public's hands as a part of the political policy-making process.
Well, let me take an alternative position. If you look at most developed countries who have universal health care they don't ask people to pay a lot in co-payments or deductibles. Very little in some countries, none. And they still do a better job of controlling their healthcare costs while providing quality care than the US does. We also know that if there's higher cost sharing, people will put off getting care, whether the care is needed or not needed. And let's assume for a minute that most of the care is needed. We don't really want to put huge financial incentives in front of people for them to not get care. We also have to look at the entire population and how many people are open to and interested in evaluating a lot of data on quality and cost. There are a lot of people who are not that literate as well as not that interested, and they won't respond. So how do we design a system for everybody?
I think in some ways, healthcare is a unique area in terms of what people understand and what they really need to understand. I think Margaret's point is well taken, that other countries, your citizenry does not need to be as educated at their third-party health insurance coverage, the premium paid by their employer versus paid out of their pocket, because the system is universal. It's paid for by widespread taxation, and you don't need to know these individual numbers. And I think the interesting thing we're talking about here is a way to do an American system of healthcare, because this isn't the way that other countries do it. And the reason why we're talking about competition and choice and information is in large part because we're trying to find a way to convert our current fragmented system into something that is a little bit better. I think is what we're talking about, which is why we kind of need to take solutions from all over the map, because we're trying to slowly inch our very large system to a better place. So I just think that's one of the part of it. And in terms of educating the public, we try and talk to the public about very large numbers, about the budget deficit, about the federal debt, about taxation. We also have to go through multiple channels to get that information. We educate the media. We go directly to the American public. We have people that are devoted readers of our issue briefs and our blogs. We also have social media. So I do think it's kind of put everything out there in ways that are understandable. And I think we try and make the world a better place by doing that. But I don't think we are going to succeed in having 300 million Americans know exactly how much of their tax dollars go to pay for the Defense Department versus foreign aid versus our healthcare system. So I think information is very important. I really do think the way forward for us in healthcare is to make the most rapid changes. We need to get more information to doctors and have the incentives to your doctor be properly aligned, because that is the kind of trusted hub of information in our system. And honestly, again, as I mentioned before, that really is the way that we started over the last 5 to 10 years to try and change our system, to pay for value from our providers as opposed to volume. Because again, we're seeking a uniquely American solution because of this very uniquely fragmented system that we're living with.
And I add one thing actually in favor of our system. And we're talking a lot about what's wrong with it. But as we see with the development of a vaccine for COVID-19, America leads the way technologically in the healthcare sector. And people often argue that we should have a system, some people argue that, say, like Great Britain or Canada or something. But my simple retort is Canada can copy the United States. The United States can't copy Canada. And that's because if you're the leading country or one of the leading countries in the development of new procedures and new processes and new drugs and new technology, the healthcare sector 20 years from now is going to be, probably over half of it's going to be something we don't even know fully today. And we really want those improvements over time. And so these incentives we're talking about in terms of, sometimes we put it in terms of cost, it's probably a little misleading. We're really talking about, and I think everybody's spoken to this, certainly Mark has as well, is we're talking about efficiency, cost relative to benefits or benefits relative to cost. That's what we're trying to maximize. And there is a part of our system, this ability to create these improvements, often at excessive prices. But this ability to create these improvements means we really can't just go off and create a national health system with some government control or something else on what's going to be produced, because as much as I'm not opposed to progressive government in any way, for the government to decide what the healthcare industry is going to look like 20 years from now is like trying to nationalize steel and decide what it's going to look like, which has always been a mistake. You can't do that if you're a leading country technologically. And that's part of our dilemma, I think, in this system.
I go back to the idea that I think, by and large, most people are trying to do the right thing as opposed to trying to do the wrong thing. And when they make bad decisions, it's because they don't have enough information, or the constituencies that they're trying to satisfy or serve don't have the right mix of information. The question is, can you produce a better analytical process for the decision makers so that they are more sensitive to what's working and what doesn't work, or at least more sensitive to the consequences of the actions that they're about to take?
I think the people in Washington are looking to do the right thing. The challenge is to deal with a process that doesn't have the discipline that the private sector has. There are two pieces of the process that are important. The process is one we call control cycle, where you basically establish the program you want, quantify the expectations on that program and the management things you have to do to get those expectations. You monitor that program year to year, determine where whatever you're doing isn't creating the expectations, and then you adjust the program to make sure it's back on track. What we want is sustainable and fair programs long term. That kind of process is really important in keeping things on the right track. One of the things that is really important that is a component of that process is having a model that reflects all the management actions you are planning to take, as well as the behavioral expectations of all the parties involved resulting from those actions. The bottom line is a disciplined process is really an important part of that process.
Let me respond a little bit. If you go back to the discussions we've had and the model we were working on, we look at cost, we put coverage, we look at health status, we look at access, we look at economic implications, and we look at long-term sustainability of the system. So, discussion we just had on other countries, what are some of the characteristics? The United States has the best treatment for serious illnesses of any country by far. We have created a situation where the health status of our population is substantially worse than all those other developed countries because we have problems with opioids, which cause massive cost problems. We have more suicides. We have higher levels of diabetes. And in fact, the life expectancy of the under 65 population in this country has gone down, not up the last couple of years. So we have created a lot of problems in our system, not just cost, but health status. We have access problems for certain parts of our population because we don't have timely coverage for uninsured. Medicaid people have to go to the emergency room quite often. So there are so many issues and problems. And when we look at solutions or ideas, we have to look at all those simultaneously. We can't just look at cost or look at how to treat one group of people, because that creates all these consequences for other groups that are not considered. And without that type of information, we're apt to make very poor decisions.
Is it your sense that the United States Congress, when they vote on these bills, has the information that they need in order to make an informed decision about the impact of their vote?
I think that for the most part, the US Congress does have all the information they need. I think one might even argue they have too much information in that we have gotten off a policymaking process that depends on a few trusted analyses from the Congressional Budget Office, the Office of Management and Budget, maybe the Congressional Research Service, maybe the Government Accountability Office. Those really are the cornerstones for our policymakers to understand what they're legislating about and make some better choices. I think our current environment has minimized the expertise of those groups in favor of even more interest group and partisan analysis. So in our current partisan, highly competitive legislature with often a divided government, you wind up getting not much done because we can't agree on the facts of which we're debating. I think it's pretty clear the Congressional Budget Office is as good of a analysis organization we can give to Congress and is nonpartisan. Whether members of Congress take their scores into account when they vote to cut taxes and increase the debt or raise spending and increase the debt is a separate question. But they do know how much these things cost. They just have political incentives that align to have them ignore those costs because to do otherwise would mean they would increase the chances that they would lose their jobs. So I think it's really the political incentives more than the information at their fingertips that is the issue.
I don't agree with that answer in part because I don't think CBO or any looks at health status of the population at all. They don't really look at access at all. And they really don't worry much about sustainability of the system because they have 10-year windows. They do look at cost and coverage in incredible detail and economic implications. But until you look at all of those items combined, I think they're operating at a very substantial deficiency in terms of information. I agree with a lot of what you said, but I don't agree with that element of it. They're missing critical pieces of information that need to be balanced to make good policy decisions.
And let me leave the congressional side for a moment. There are other audiences out there. Obviously, there are the providers, there are the consumers, there are their employers, and the question of whether or not they are getting information that would be useful to them. So, Mark, I'm going to ask you to start. You know, we use the word holistic analysis a lot, and I'm wondering if you think about those other audiences and the grid that you put together, if you could talk about why you and others obviously believe that there is an information deficit that would make a difference both to the discussion and to the search for solutions in American healthcare right now.
From the perspective of whether it's an employer, insurer, provider, government, they all have different perspectives. From the standpoint of employers, healthcare costs have become a serious problem. And so I think they're probably getting information that they think they need. They're just not finding the ways to keep their business going and keep the costs from those fringe benefits to a manageable level. From the provider's standpoint, they're very frustrated because they have the insurers and the government continuing to put new restraints on their reimbursement systems, which create great cost shifting. They want simplicity, but I think they're flummoxed as to how to make this system work. So I think they're probably looking for any new information. The government's obviously looking for budget solutions, as Gene talked about and Josh talked about. And the insurers are pretty much into the Medicare Advantage and Medicaid business. The private market, they're not doing very well. Their margins have shrunk. They're under a lot of pressure. And I think they're looking for new information and new ways to improve their products and thrive in what they see as a continually more difficult market, except for Medicare, but they're worried about that. From those perspectives, I think each one has their own dilemma that they're dealing with, and most of them are looking for different ways, and they would want information to help them come up with a better strategy.
We don't seem to be recognizing the value of the healthcare system when it does work in full value. Gene, in your article, make the argument that there is unrecognized value that should be recognized in terms of when the system is working, whether it's a healthier workforce or it's school cost or whatever. And the question is, how do we get to the point where we actually recognize the value?
Frank, a lot of the gains are outside of healthcare. So if the gain is only, I'm going to take, $1 trillion over the next 10 years of health costs and switch it to another $1 trillion of healthcare costs, I think that's dodging the issue that a lot of the gains are outside the system, which is reflected in the excessive prices. So if we could sell it on the fact that we're going to do this in a way that allows shows that we can allow cash wages to go up, and we could start spending more money on education and other things like that, that could make a difference. One item I did mention earlier, but is in this C.J. Kwan article, as well as people wanted, I'll send them other information, is all of the growth in government spending now, all of the growth outside of interest on the debt is going for Social Security and healthcare. That's it. Whether you take Obama's last budget, you take President Trump's last budget, they differed on whether they wanted to subsidize the non-elderly, but it was all health and Social Security, and everything else is getting squeezed. And so to me, if you really want major reform in this area, and health is just a big piece of it, you've got to put together a package that sells to people what this is going to do. At the end of the day, as I say, there's two pieces I've talked about today. One is I think you've got to put every government subsidy in some sort of budget because it's the budget constraint that forces the efficiency decisions. And the second thing, which is not unrelated to trade-offs even between health and outside of health, I think some of the gains in healthcare, you have to allow people to choose if they're getting a lower cost policy, and they're going to see immediately some of the gains from that. So that's sort of my attempt to approach these issues holistically. That asks for a great deal. I don't think it's going to come about because some member of Congress figures out he's going to identify a few losers and have them all riled up against him in order to create a few winners over somewhere else. I don't think that's going to get there.
I think we should do our best to correct the market failures and misaligned incentives. Quality information is going to be important to making any of those work. Information on costs is always good. We don't have good comparative effectiveness measurements of new procedures, new drugs, new ways to treat. And of course, the actors in the system don't have great information about costs. And then I think making that more rational is something that we need to find a way to have political incentives in our system align so that they can make those choices.
I think it's terribly important to have the incentives aligned in the right way. And it's important to put more pressure on the healthcare system through purchasers, federal government, state government, and private employers banding together to be very clear about what changes they want, what measurements they're going to use, and how the providers will be rewarded for responding to that. And unless you have adequate market share being applied to these problems, you're not going to see the kind of changes you want. And I think that can be done without necessarily a lot of legislation.
I've spoken mainly about two legs on a three-legged stool. One leg is I don't think any efficiency gains or that set of incentives works unless you have budget constraints. The second leg I applied is that consumers somewhere or another have to see some of the gains directly, not just indirect gains through expecting budgeteers to eventually give it to them. But the third one are the issues that other people on our panel have also discussed about, which is better information systems, better knowledge about quality, better sets of incentives. That's really the third leg of the stool. My only point is that third leg, these information systems, these quality improvements, and I think there's a lot of work going on in this area, but they only work if you have the other two legs. So they're really three legs involved here. And I think all the members of this panel have done a really good job in discussing a lot of the options that are before us.
The consumer deserves to better understand what they as a consumer are getting from the healthcare system and what that healthcare system will look like 5, 10, 20 years from now when they will continue to rely on the system for support.
We need a process that works. We need principles underlying it. And we need checks and balances. So as Gene said, we have an open-ended system. There's no checks and balances, and the process is broken. So we need to go back to tackling and blocking the fundamentals to get this fixed.